Hello and welcome everyone. I'm Cori and I lead the Global Ideas for U.S. Solutions team at the Robert Wood Johnson Foundation. Thank you for joining our Reimagined in America webinar. Before we begin, I've got a few things to tell you. First, we've muted everyone's audio because there are lots of people joining us today, which is wonderful. Second, if you're having any kind of technical difficulties, please send us a message through the chat feature or call Jackie on the number on your screens. Third, the webinar is being recorded and we'll be sending everyone a link to that when it's ready. And lastly, we really want to have a conversation today, and that means we want to hear from you. Please send us your questions and comments by clicking on the Q&A button at the top of your screen. All right, so let's begin. We're here today to get inspired by ideas from outside our borders. In the United States, we love to adopt ideas and practices from other countries and make them our own. From big ideas like democracy and inalienable rights, to everyday foods like bagels, pasta, and tacos. So why aren't we looking abroad for solutions that improve health and well-being? Well, that's exactly what we're doing right now at the Robert Wood Johnson Foundation, working together with people across the country and throughout the world. One reason we do this is that we really believe that once you look at systems that are radically different from our own, it helps us to see our own system from a different perspective. It unlocks our imagination so that we can accelerate our nation's progress towards a culture of health. So what's a culture of health? It means that everyone, no matter who they are, how much they earn, or where they live, has the chance to live the healthiest life possible. Another very pragmatic reason for looking outside our borders is that other countries have solutions to some of our biggest problems. You might know that Americans have shorter life expectancies than their peers in high-income countries like the UK or Japan. But it's not because we don't invest in healthcare. We actually spend far more on healthcare than any other country. So what are those countries doing differently to get better results? Well, actually, they're doing a lot. Many countries have made different decisions about healthcare delivery, about payment structures, and about the priority of prevention, among other things. And today we want to focus on how patients and providers in other countries work together to build health. So what are the goals for today's conversation? We want to learn something new from your comments and questions. We hope that you'll learn something new from our speakers. And we hope that we all leave inspired to look abroad for solutions. But first, we want to do a quick poll to learn a little bit more about all of you. Now, you should see a prompt on your screen. There are two questions. The first is multiple choice, and the second is a simple yes or no. And so just click on the answers that apply to you. So the first question is, why did you join today's webinar? Please just click on the right answer, the answer that applies to you. The second question is, have you or your organization ever looked abroad for answers to tough questions? All right, last chance to vote, and let's take a look at the results. We're tabulating them now. They will be coming at any minute, I'm sure. Here they are. All right, so this is really interesting. So 76% of you are really interested in the concept of learning from abroad. 27% interested in learning more about patient engagement. None of you were looking for cat videos, so that's a good thing. And it's great to see that 70% of you have looked abroad for answers to tough questions. So that's very interesting. So now let me introduce you to our two speakers. Dr. Krishnan Kumar works with innovators across the world to scale and replicate successful healthcare delivery solutions through his organization, Innovations in Healthcare. He'll talk about what we can learn from other countries about expanding patient engagement and decision-making. And Dr. Cory is a gastroenterologist at the Dartmouth-Hitchcock Medical Center in New Hampshire. He'll share the story of how adopting an approach from abroad moved his healthcare practice to a place where healthcare is co-produced by patients and providers. Let me turn it over to Krishnan.
Great. Thank you, Korobi, and thank you for the opportunity to be here with you today. Through innovations in healthcare, we source, strengthen, study, and scale the most promising innovations to increase access to quality, affordable healthcare worldwide. And in that work, where we work directly with 74 organizations offering health services and technologies in over 70 countries, what we've started to see is that communities and countries around the world really are struggling with the same challenges. How do we make sure that everyone in our society has access to critical services and technologies? How do we ensure and improve the quality of those services and make sure that health and social services are affordable, especially to our most vulnerable population? In addition, as populations age, as we recognize the growing burden of chronic diseases, and as we also see both the burden itself and the influence on physical health of mental health challenges, we're also starting to see a convergence amongst the health challenges that people are trying to address, whether they live in low, middle, or high-income countries. When we think about where the best ideas might come from, we have a tendency to go to those bright spots, the places that are most advanced. You might think about looking for the best technologies here from the United States or parts of Western Europe. And what we've actually started to see in our work is that some of the best, most creative, and potentially transformative solutions are actually being developed in parts of the world where you would perhaps least expect it. And especially happening in resource-constrained settings, where we know that people are being forced to think creatively to use limited resources most effectively to address critical health challenges. I want to tell you the story of a couple of these examples to give you more of an idea. The first is an organization that's called Basic Needs, and they work in 12 countries across Asia and Africa, working to empower and improve the lives of people with mental health challenges. They do this by forming self-help groups, by better using and coordinating community-based mental health services, by providing vocational training and reintegrating people with mental illness into their communities, and making sure that they study what they do so that they offer evidence of their own impact. We know that mental health is a significant challenge for almost every community here in the US. So by learning from what's happened in parts of Asia and Africa, we were able to work with Basic Needs with support from the Robert Wood Johnson Foundation and create a new demonstration program in Detroit, working with a local partner, Southwest Solutions, that's now bringing this global best practice here to the US to serve our local communities. The second example I want to give you is from south of the border. If we look at an organization called Medical Home in Mexico, they have partnered with the largest telecommunications firm in Mexico to provide a call center-based access 24 hours a day through a subscription service to talk to a doctor, a nurse, a nutritionist, or other health professionals anytime you want from anywhere in the country. And we know that they've now offered this service to more than 10 million phone calls that they've received and are able to answer and resolve questions more than 60% of the time. And through this, they're able to make access to health advice and services much more affordable to people who need it. And not only that, we know that there are communities in the US that could benefit from this same type of service. In a partnership with a US-based organization called Consejo Sano, the same model of a call center to be able to talk to a doctor to help navigate appropriate health resources here in the US is available to people that are Spanish-speaking here in the US. We know that almost 50 million people are Spanish-speaking here in the US, and many of them don't have access to language and culturally appropriate care. So by learning from what's happened in Mexico and adapting that model, Consejo Sano has been able to improve access and affordability for many people here in the US. Through these examples and through our broader work, what we continue to see over and over is that one, the challenges that we're all dealing with, the needs of our communities, of our patients, really is more similar than it is different as the world converges on similar health needs. Secondly, we've seen that engaging beyond borders can really help to match the needs with the best solutions, whether those are emerging from our backyards or from halfway around the world. And third, through our work and with partners, we've also seen that there are pathways that make it more likely to succeed to think about adaptation and even looking at global best practices. The perspective that we bring is that once you understand the challenges you need to solve, there's an opportunity to really source and curate the very best solutions from all over the world to think about how they may be adapted to the local context, to put them into practice, to demonstrate and refine and show their effectiveness, all toward a pathway to scaling its impact. So thank you for the opportunity to share today, and I look forward to a lively discussion.
Thanks so much, Krishna, and let me turn it over to Cory.
Thank you, Krishna. Thank you, Karobi, and it's a pleasure to be part of this program. What I'll talk to you today about is how we're learning how to treat patients better in inflammatory bowel disease here in the US from what we've learned abroad. As a gastroenterologist, it's easy to recognize that patients with Crohn's disease and ulcerative colitis, which make up the inflammatory bowel diseases, really present in so many different ways. But what's more troubling is that these patients are cared for in completely different ways, no matter where you are in the country. If you look at this map here, this is not showing where patients with Crohn's disease are in the United States, but it's showing you of the patients with Crohn's disease, the proportion of those who are being treated with biologic therapy, such as infliximab or adalimumab, which you might recognize as Remicade or Humira. There's no way that there's so much variation in the patient's disease severity, zip code by zip code, that would warrant this variation. It has to be the way that the providers are offering care to these patients. And we need some way to close the gap of variability and offer a more uniform level of care across the country and across the world. So to understand more about this, we had to turn to others and see what they're doing. Through my partners here at Dartmouth, at the Dartmouth Institute for Health Policy and Clinical Practice, we learned about the amazing program in Sweden, using a registry-based learning health system to take care of their patients with rheumatoid arthritis. They proposed using this partnership for co-production, where patient families come together to give data to the program, providers and the care teams feed forward clinical data, and working together with patients and engaging patients as partners in their care. They used a shared data environment, a registry-based environment, to learn what they can from patients, make small tests of change, and understand how they can improve care collaboratively as a learning health system, as opposed to doing it as a single visit between patients and their providers. They instituted a couple of different programs. One is to develop these dashboards where they gather information from patients before visits and in between visits to understand how they're doing, so that at a visit, patients can sit with their providers, see their progress on the dashboard, and really engage in their care in a much more robust way than they had in the past. Since they initiated this program, they've seen great improvement, not only in their inflammatory markers, which is the graph looking at here, which is measuring the C-reactive protein. But what you can see, look at the blue line. This is the variation between different clinics throughout Sweden. And you can see that not only does their inflammatory burden come down, but the variation between the clinics tremendously comes down as well by offering a more uniform level of care, by engaging patients and working on this concept of co-production. So working in partnership with the Crohn's and Colitis Foundation America, working with the Dartmouth Institute and our collaborators nationally, we developed a program called IBD Chorus. IBD Chorus is a national quality improvement initiative that's centered on improving the delivery of IBD care for adult patients. The learning health system engages IBD patients and their providers in implementing best practices and standardizing care. The way it works is that sites share improvement efforts designed to systematically drive sustained improvements in healthcare delivery, following, of course, the triple aim, looking at improving the patient experience, health of the population, and value of healthcare. We're engaging all sites to work together so we can learn from each other, learn from our patients, and spread it through the rest of the collaborative. This will look very similar to you. This is taken, of course, from the Swedish program, where we use the shared data platform, this partnership for co-production, and then layer on top of that quality improvement methods to look at specific initiatives within our program that we want to improve. Specifically, We used the Institute for Healthcare Improvement's Breakthrough Series collaborative to focus on urgent care delivery. We learned very quickly from our collaborators in this program that bad things happen to patients with inflammatory bowel disease when they go to the emergency room unnecessarily. They get CT scans performed, they're given narcotics to treat their pain, they're given prednisone, which quickly treats their symptoms, but ultimately leads to bad complications. So we worked together with our groups to see how we can learn from each other, learn from how sites are doing this to keep patients out of the emergency room. And we made some great strides. We also started to develop care pathways around things that we as gastroenterologists simply think we're bad at. We think we're bad at identifying patients with IBD who are malnourished, and we're not so good at identifying those who are anemic and then knowing what to do about it once we find it. So by developing standardized care pathways, we're able to initiate these throughout the sites, engage patients in this process, and then hopefully improve optimal health and high-value care for all patients with Crohn's disease and ulcerative colitis. This is what we call our co-production dashboard. Again, it looks similar to the Swedish model. There are a couple things I want to point out here. This is shared at the office visit when patients come in. We sit with the patient and look at their progress over time. What we can see on the left side are their disease characteristics. So immediately, the provider's reminded of exactly what their disease has been like and how long they've had it. The number one concern has been probably the most important thing that we've done to engage our patients is we ask them a question in a pre-visit survey that says, not only do we want to hear about your symptoms, but we want to understand what the number one thing that you want to address with your provider at this visit is today. We encourage them not to talk about their symptoms, but let us know about things coming up in their life, such as weddings, or worried about having children, or other ways that their disease impacts their life. I'll show you an example in a minute. Up top, you can see we see patient-reported outcomes, and then we have some clinometrics on the right, something called a C-reactive protein, again, that looks at their inflammatory burden. We track their symptoms over time, and then along the bottom, you can see their medications are charted along that same time period, so we can match up their symptoms along with their medications that are being used. Just to show you one number one concern we got from a patient to show you how important this is a young woman who came in that actually was feeling fine. She came to the visit and had nothing to say about her symptoms. She thought she was doing great, no problems with her medications. But we had an amazingly fulfilling visit when she mentioned that she was most concerned about needing surgery and how that would have impact on her ability to have children, which really brought an incredibly engaging and important conversation that I'm not sure would ever have happened or could have happened with the last 1 or 2 minutes of an office visit. Our program is now spreading throughout the United States. You can see here the blue states where we have a site, and then the darker blue icons are showing academic sites. And incredibly important is we've engaged many community gastroenterologists across the country to be part of the program that have really taught us so much about what IBD care is like in a community practice as opposed to an academic practice. We continue spread throughout the United States. Currently, we have these 30 practices that follow approximately 40,000 IBD patients. We hope to expand that 30 practices to 60, 90, and 100 practices over the next few years. Practices are ranging from about 700 inflammatory bowel disease patients to up to 5,000 or even more. Each physician has a team with at least a team leader that can be a nurse, a physician, or a research coordinator. And then we encourage all sites to involve patients in the leadership of the program as well. And from the very beginning, we're very proud to say that we've had patients as part of all the planning groups and leadership groups for IBD Chorus. The idea is to learn what we do here, spread it throughout the United States, and we're now thrilled to hear that what we took from abroad, what we learned in Sweden, is now being used in other parts of the world and other disease states such as cystic fibrosis, rheumatoid arthritis. Teams in Canada and South America are now building programs similar to IBD Chorus and thinking how they can get involved. And we're meeting with teams in Europe as well who are interested in spreading this there. We've learned a lot from abroad. We never could have done it by just looking at the United States and seeing how people are doing things here. And we hope that we can spread what we've learned throughout the rest of the world.
Thanks so much, Cory, and thanks again to you, Krishna. It's great to hear your experiences. So now let's turn to questions. And just as a reminder, to ask a question, please hit the Q&A button, which is at the top of your screen, and type out your question. And while we wait for questions to come in from our audience, I just wanted to start with one question myself to both of you, which is what surprised you most about learning from abroad? And maybe, Krishna, why don't we start with you?
Sure, thank you for that question. To me, what's been most surprising is, in fact, how open people have been to this concept. Oftentimes, we get caught up in looking at things like comparative health systems and why something that might work in Europe could never work here. But when you really get down to trying to solve real problems for real people, there's openness, because whether you're approaching this from the perspective of a patient or consumer, an employer, a provider, at the end of the day, we want to do what's best to provide the best screening and treatment for individuals in our community. So we've really been surprised by how willing people are to engage in thinking about understanding best practices from around the world and how they may be adapted for local settings.
Great, thanks. Cori, do you want to answer that question too?
Sure. For me, the thing I was most surprised with was really how we can use approaches that are done in different parts of the world and in completely different disease states and apply it to what we're doing in our own practices, whether it's myself as a gastroenterologist or an endocrinologist, perhaps applying this to diabetes. And what we learned when we first saw the dashboard from Sweden, not only was it about rheumatoid arthritis, but it was in Swedish, and I wasn't even exactly sure what they were tracking, what they were asking patients, but we quickly learned that this approach of co-production was about engaging patients, having them more involved in their care, working more closely with their providers, not just as a passive patient, but somebody who is really involved in driving their care forward. And that was easy to translate to our patients and what we wanted to do here. And then in turn, I was recently at a meeting in Europe and met with some gastroenterologists who heard about what we were doing with IBD Chorus with the Crohn's and Colitis Foundation, who were from Belgium, and asked how they could possibly get started. And to hear where they were was exactly where we were about 2 or 3 years ago. And to be able to then take what we've learned, again, from a different country, a different disease state, and then turn back and help them learn how they can adapt it to their own system was something that was really a pleasant surprise to me of how we can help others from what we're learning.
Great, thanks. So we have a question from the participants now, which actually I think is a great follow-on to that question, which is, have any of you encountered resistance in accepting ideas from abroad in the US? So for example, have people you've worked with or tried working with said that there are too many cultural or system differences? And you were touching on this a bit, Cori, both of you were. So whoever wants to jump in on that one.
Yeah, I can start, Krishna, if that's okay.
Sure.
There are definitely some differences in the healthcare system in the U.S. and in Sweden. And for instance, there's a big part of the Swedish program is around telehealth and remote contact with patients from nurses that I think is gaining interest here in the United States. But from a reimbursement standpoint, from an expectation standpoint about patients who want to drive to the office and sit there in front of their doctor as opposed to a telehealth visit over the internet with their nurse is a big cultural shift. And again, all the reimbursement issues and licensing issues really need to be worked out here in the United States. So that's something that I think will come a little bit later in how we take those aspects and incorporate it into our program. But at a basic level, there were some significant differences that we had to adapt to and really change the format of how our program would work as opposed to what they were doing in Sweden.
Great, thanks. And Cori, I know you talk a lot about sort of taking the principles from Sweden and really putting it into a very different system. And I wondered if you'd want to expand on that a little bit.
Yes, sure. So, the principles of co-production, at least, is definitely something new for many of our colleagues. And again, not just in gastroenterology, I think in medicine in general. In the US, we have way too much of a paternalistic approach to taking care of our patients. The concepts of shared decision-making and patient engagement, everybody wants to do, but doesn't feel that they have time to do. And what was a barrier, I think, at first when we start presenting to our colleagues of how we want to do this and how we want to bring patients into the program, their initial instinct is to worry about time and how are they going to do this on top of all the other things they do. However, we've learned that there really are some ways to use this as a more efficient way to take care of patients. For example, the pre-visit survey that we send out to patients asks pretty much all the questions that the provider would want to ask a patient when they come into the office. So instead of being bogged down by another survey to look at or another system, what I have is actually a head start on the visit. And I see that patients have already answered all these questions. And before I even walk in the office, I know how they're doing. So the reason we did that was because I heard that pushback early on. And when we were working as a group here at the Dartmouth Institute and working with the Crohn's and Colitis Foundation and working with patients and other providers, we learned from them what their concerns and barriers would be and the type of system they were doing elsewhere and how we might incorporate that into a US system to make things more efficient and actually keep things moving along as opposed to extra work that it was perceived that it could be by engaging patients in their care.
Great, thanks. So another question from the participants. This is to you, Krishna. How do you identify programs around the world to adapt in the US? How do you find them?
Sure. So over 6 years, we've refined our model of what we call innovation scouting. So we have partnerships with over 300 other individuals or organizations that are all around the world that are our eyes and ears that look for organizations that are providing services or products that have proven to be significantly improved. And the criteria we use is cost, quality, and access, or and said differently, the triple aim. So where are there organizations that in their local context have actually achieved the triple aim of improving care, improving health, and reducing costs? And then we study those to see what makes them successful. What is it about the models themselves? And also, what is it about the ecosystem in which they exist? And that gives us a better idea of how much is generalizable versus how much is just part of a unique situation that it may not actually be adaptable. And once we do all that, we try to match to make sure that it's solving real challenges. And more, we've tried to flip the model rather than innovation scouting to really start more with this idea of problem sourcing. So really to figure out in a very detailed way what problems people are encountering, what are the specific health challenges that we don't have great answers for, and that allows us to be much more focused in trying to find the best solution and figure out which of them may be adaptable to meet those needs.
Great, thanks. So another question. So she says, thank you very much for sharing these inspiring examples. Can you share a bit more about how you learned about these international examples before adapting and implementing? And there was another related question to you, Cori, about how did you find out about the project in Sweden? How did that come to your attention? Cori,
well, thank you. Yeah, thank you. So the, how we learned about Sweden was one of the advantages of being at, a great institution with great people around me. So, talking with my colleagues here at the Dartmouth Institute, I actually approached them about something really different. I wanted to learn about other models of that were going on in this country, specifically around cystic fibrosis that they've been very involved with, in the Northern New England Cardiovascular Disease Registry that they've been very involved with, and wanted to learn what they were doing. And it was in fact them that said, although we helped create these models, there are actually some amazing work going on abroad, and introduced me to the leadership of the Swedish rheumatology program. And we were fortunately able to meet with them and ask not just what made their successes, but where their failures were. And that's something that we should always emphasize when we're talking with others who have experience, is not just to adapt exactly what they've done and make it your own, but see where they fell down early and where they had trouble. And that probably guided us more even than their successes later on, is seeing really what were the struggles, like the question before, what were the barriers, what was the hesitation of their colleagues to get involved, and what were the things they used to help engage their colleagues and really to engage patients. And to us, learning how they engaged patients and brought them into the care system and allowed patients to really feel part of their care was what drove us to create this co-production system and use that model. There was another part of that question, I'm sorry.
Well, just sort of what did you look for?
Oh, sure.
And that could be to both of you, sort of, as you're assessing examples before you adopt and implement them.
Yeah, sure. Well, to us, it was the success that they had, not only in the engagement of the providers and patients, but they really had terrific success in decreasing that variation and improving health in the patients that they were providing this to. So take an example that not only sounds great, and not only that you think would be perfect for the patient population that you're caring for, but really looking for some objective evidence of success to make sure that you don't spend a lot of effort building a program based on the concept of it, but really the proof that it's been effective.
Yeah, and I fully agree. For us, what we look for are organizations or programs that can be effective, sustainable, and scalable. So even if you've got the greatest delivery innovation or a new model of care, if there's not a business model or a reimbursement model that actually makes it sustainable and scaled to reach population levels, it's really difficult to find ways to adapt and integrate it.
All right, great. So we have another question. Have either of you heard about the Global Center for Health Innovation in Cleveland, Ohio? And then just more generally, what is your thought about the importance of innovation centers here in the US in helping to accelerate this kind of progress in healthcare? And Krishna, that sounds like that would be right up your alley.
Sure, I have heard of that one particular, and I'll perhaps generalize to say I think there's a huge need for and role for innovation centers. They come in all sorts of sizes and flavors, which makes it hard to generalize, but I think a systematic approach to really trying to find solutions, adapt them to local contexts, and also empower our frontline providers and managers to be part of that solution development is really important. In fact, to go along with our work here at Duke, we've just launched a Global Health Innovation Center that will serve as the interface to all of our global activities to bring it more directly into our own care delivery environment as an academic health system, to make sure that while we're engaging around the world to look for solutions, we're both looking for solutions from home, but also adapting all of these global lessons learned to improve the health and lives of our own patients.
Great. Cori, did you want to weigh in on that question as well?
No, I think it's a great idea. I completely agree. I mean, we need to, stimulate all of what people are doing from an innovation standpoint. And you can't innovate without sitting down and trying to. It doesn't happen in your spare time in between patients or during a busy day. I mean, it's something that with our program, being able to have the support from the Crohn's and Colitis Foundation, being able to be forced to think about new ways to deliver care is really what allowed us to do what we do. But this idea of innovation centers and people working together, really is what's going to push it forward. It doesn't just happen by itself. Great.
So we've actually had a number of questions around the social determinants of health. And so there's one in particular, but I think it's a more general topic around social determinants of health. So this is from someone who says, I work in maternal and child health, and I'm interested in social determinants of health in populations. I wonder if the speakers have comments or observations from other countries about social and economic policies that seem to really make a difference in health outcomes. Krishna, would you like to start with that?
Sure, and first of all, I think we should recognize that healthcare is the minority of what determines health, as more and more data reinforces that. So we certainly believe that you need a more holistic approach to improve health at individual and population levels. Some of the models that we are seeing are around things like leveraging social networks and behavioral economics to try to incentivize, whether it's on the supply or the demand side, really matching needs and providers of services to be more effective. What we're also seeing on the ground be very effective is the integration of social and health services This is oftentimes, a tension point in national or state level policy conversations. But when you look at a grassroots perspective at the community level, when people are better coordinated in terms of being able to access health and social services, we see that really paying off in terms of creating meaningful improvements in health. So we believe that you have to align the policies, you have to align the payment systems, and you have to align the delivery of services and technologies to orient toward individual and population health. And the innovations we look for are really to fit into that framework. One other point I'd make is oftentimes what we see are what I will call point innovations. It might be a single technology, it might be a new model of health professionals or community health workers. And to address complex health challenges, what we've started to see is you actually have to take the best point innovations from all over the world and find ways to integrate them and bundle them so that they are better able to address the whole of a complex health challenge.
That's very interesting. Very interesting. Anything you'd like to add to that, Cory?
Yeah, I will. This is an incredibly important topic, and although we haven't designed our program to really address this issue, it does in ways that was somewhat unexpected. So if you remember the question I showed you, we ask all patients, which is, tell us about your number one concern coming to the office. And a good proportion of these answers are around cost and access. And I'm almost embarrassed to say that this isn't something that was typically part of my day-to-day interactions in the clinic. I would ask them about their symptoms, I would adjust their medications, I would make sure they got their laboratory testing. I might, on a good day, ask to pry out of them, do they have any other questions that they want to bring about their care? But now that we're asking this open question to tell us what they're concerned about, and we actually have cost of care as one of the examples that they should ask about, it's amazing how much we're hearing from people about their concerns about losing insurance, about not being able to afford coming in, not being able to afford procedures. And it really opens up an incredibly important conversation that we need to have with our patients at an individual, case-by-case basis in the office. Of course, we need to think about the global public health and policy, but in the office, when our patients are coming in, I loved what Krishnan said, that, health is not just about health care, it's about all things that go into what patients and people need to do to have good and healthy lives. And we need to get some insight into that. And if we don't ask them when we're in an incredibly busy, overbooked clinic visit, when we're rushing to get through a 20, or if you're lucky, 30-minute visit, these are things that we need to stop and think about with our patients. And by the way we did it, with using this idea of co-production, of allowing our patients to tell us what they're worried about and what they're concerned about. And it opens up this whole conversation about healthcare costs and access and other determinants of good health.
Here, I will say, and on that note, I'll also just put a quick plug in for, future webinars where we will be looking a lot at the social determinants of health. So please join us for those. So we have time for one last question. And the question is, what role have non-clinicians played in these models? And has there been any success in collaborating with community partners and other non-traditional partnerships? And I know Krishna, that in your work, particularly with basic needs, that has been a part of that work. So I don't know, maybe you would like to start.
Sure. I think we see a huge role for non-clinicians, in fact, leading much of the change that's required, whether it's empowering patients and communities through self-help groups and the like, or creating shared decision-making or co-production models. We also see a huge role for community health workers that are not traditionally trained and certified healthcare providers. Employers are playing a large role because they are worried about the health and productivity and frankly, the healthcare costs as a benefit to their employees. So a lot of what I think is needed is getting the right stakeholders to the table, and it's not just providers, but many non-providers who really are invested in their communities and in the health of those communities, and And that's where we've seen a lot of success come from. Another point, because a lot of what we look at around the world are startup organizations. And many of the most promising ones we've seen have been started by people who weren't part of the health sector and certainly weren't providers. So engineers, people coming from the consumer goods industry, people who can bring fresh eyes to healthcare and oftentimes recognize when we're not using common sense and really be able to build new organizations and create new solutions in ways that those of us who have come up through the traditional model may not be even open to.
Great, great. So I'm told we actually have time for another question or two.
And maybe I can just add one comment to Krishnan's response, if that's okay, on the last question. That this idea of bringing others in is so important, and not everything. I fully agree with everything Krishna said about learning from others, even outside of healthcare. But a critical piece of our success thus far, and I think will be the key to the success in the future, is how we engage patients in the development of the program. And once you start opening your eyes to the fact that we do things all the time in our clinical practices and research world, where we are trying to make care better for patients without asking them what that looks like, it almost becomes difficult to do anything without engaging patients and bringing them into it. And by asking patients really what they needed out of this program, but also asking them to design the dashboards and the questions and be part of leadership decisions, has been so important to focus on the patient-centeredness of the program. So of all the people that we've engaged, and we've worked with psychologists and computer programmers and business people to think about how to sustain the fundraising of the program, and dietitians, it's really the patients that keep us on track in what we need to do. And I would urge everybody listening, as you're developing new programs, just to always keep patients right in the center of the planning of that program to make sure that you get it right.
Thanks, Cory. Thanks, Cory. So I lied earlier. This now will be our last question. It's a really interesting one, which is, how do you navigate issues of intellectual property? So either in terms of formal structures related to ownership of developed outputs, or more informal concerns of the appropriate attribution of innovations. I think a really interesting topic, and whoever would like to start.
Yeah, I can provide our general.
Go ahead,
Cory. Please, go ahead.
I'll just say we've certainly dealt with this as part of our collaboratory, as I called it. You'll remember we have 30 sites active and growing, and many of them are large academic institutions, and it really became a conversation early. So I would suggest the way to deal with this is to address it right up front. We actually have contracts either already signed or being signed with all of the sites to make sure that we're on the same page as far as where IP lies around any parts of the innovation. So I guess my basic advice is think of it early, look at it, face head on, as opposed to hoping that it doesn't come back and get you later, and think about a clear contracting structure to make sure that everybody is very clear on how things will go moving forward.
Yeah, I agree with that. Exactly as Cory said, I think recognizing that it's an important issue and addressing it up front, along with all the other key questions. And it's rarely about protecting patents in terms of intellectual property. It's much more about the know-how that goes into creating a new model of care. And what we've seen is when people are approached as collaborators, as equals, that they're quite open, oftentimes are very clear on their expectations of what they consider to be their intellectual property, what they're willing to share, and under what conditions.
Great. Well, I think, unfortunately, that's it for questions. I know there were a lot of questions that we weren't able to get to, but I wanted to thank again Cory and Krishna, and thank all of you who've joined us today. And I have just a couple of quick things before we're done. As soon as the webinar is finished, a very short survey, and I do mean very short, will pop up on your screen. And we hope that you'll take a moment just to fill it out and let us know what you've thought of today's webinar, and give us feedback on that. We'll also be sending out an email with the recording, and we hope that you'll share that far and wide. On our next webinar, we'll be looking at solutions from Latin America to reconnect youth who are out of school or out of work. And we hope that you'll join us for that in September. You know, so often we exclude solutions before we've even considered them. So today, I just invite you to take a moment to think about an issue you've been struggling with, whether at home or at work, and just say to yourself, I wonder if Italy or Brazil or Nigeria has figured this problem out. And while I really hope that you look to other countries for practical solutions, I also hope that when you can, you'll take the opportunity to travel abroad, whether literally or figuratively, so that you can gain perspective on our own systems here in the US. Let me leave you with an anecdote of my own. I recently heard about a company in Denmark that has their desks on a pulley system, and the desks are pulled up to the ceiling at 5 p.m. That's an idea that I think would work well in my life. So thanks again to everyone. Please fill out the survey at the end of this webinar and have a great rest of your day. See you in September.